Hello, I am pleased today to be joined by Leila Neshatian. For those of you who are not aware, Leila is a clinical associate professor of gastroenterology at Stanford University in California, where she is also the director of neurogastroenterology and motility. Leila completed her residency in New York before completing a gastroenterology fellowship at the Mayo in Rochester. Among her many roles, she is counselor on the motility section of the American Gastroenterological Association, co-chair of the Rome Anorectal Biofeedback section, and committee member of Rome 5, the Functional Anorectal Disorders Working Group. Today, Dr. Neshatian and I will be discussing the paper upon which she is corresponding author, entitled Distinct Phenotypes of Full-Thickness Rectal Prolapse in Women, a comparison of defecation-only and spontaneous presentations. To begin with, Dr. Neshatian, thank you so much for joining me.
Hi, and thank you for having me. This is an honor to be here.
Thank you. So, Dr. Neshatian, to start with, for those of us who are not au fait with pelvic floor disorders, could you first start by defining what full thickness rectal prolapse is and the differences between defecation only and spontaneous prolapse?
Very good. So rectal prolapse happens when the layers of the rectum are telescoping and moving outside of the anus. There are different levels of the rectal prolapse. It can be internal rectal prolapse, where these all layers of the rectum are just invaginating into the rectum without coming out, or it can be full thickness full-blown rectal prolapse. Well, these layers are entering outside of the anus, and this is considered full thickness rectal prolapse because all the layers of the rectum are involved in this problem. So internal rectal prolapse is sometimes referred to rectal intussusception, but in the full-blown, this is where all the layers are coming out. It is thought to be rather not really a common problem. Unfortunately, it's often associated with, in women especially, with the prolapse of other organs in the pelvis, including the uterus or bladder. We are thinking around 3% of the women have a multi-organ prolapse, including rectal prolapse in US. And there are many reasons for people to have rectal prolapse. The rectal prolapse can be mainly in the older individuals, but it can be seen also in younger people. It's more common in women, but it's not really uncommon also in men. Among the pathologies that can lead to rectal prolapse, having constipation, dyssynergic defecation, inappropriate and enduring straining can lead to rectal prolapse in many patients. Other etiologies can be any pathology that is associated with increase in intra-abdominal pressures, including those patients who have chronic cough. Those patients are at risk of having rectal prolapse. The trauma to the perineum or patients who have had significant OB trauma can be at risk. Patients with the connective tissue disorders, they are at risk of having rectal prolapse. So it is a very heterogeneous of a condition, and it can have a lot of different etiologies for one person to have rectal prolapse. I have to say, among one of the major risk factors for rectal prolapse, it is age, which is associated with changes in the skeletal muscle, with the changes in the whole connective tissue, and this is a very well-known risk factor for having prolapse, including rectal prolapse.
Thank you. So, Dr. Neshatian, moving on to your study, what were the aims of your body of work that you've published in NGM?
Sure. So I think that when we look at these patients with rectal prolapse, it seems that there are, in terms of the symptoms, there are a lot of different symptoms involved as well. And some of these patients will report having the rectal prolapse only during the evacuation and having a bowel movements. These are the patients who are coming and explaining that something comes out of their rectum when they are trying to have a bowel movement. And there are some patients who have the rectal prolapse who is more sustained. They can be having the rectal prolapse at all times, or it can be coming out when they are when they are walking or having a physical activity. So we noted that among the patients that we see, there are differences in the presentation of the rectal prolapse. And with that, thought that, okay, so why is this that some patients will have the prolapse more with the activities, or some others have more sustained rectal prolapse as compared to the patients who only have this happening when they are trying to have an evacuation and the bowel movement. And with that thought, we had this hypothesis that there are potentially differences among these patients, I'm sorry, with different presentations of the rectal prolapse, and thinking about what are the potential changes involved in anatomy and the anorectal pressure that might be leading to different presentations. We tried to conduct this study.
Mm-hmm. Thank you very much. So you've also addressed the hypotheses as well. So just again, what did you hypothesize?
Right.
To clarify that.
So looking at the patients and really based on the clinical experience that we had, we hypothesized that people who have defecation-only rectal prolapse have different features. They are more likely to be early phenotype of the rectal prolapse. And these are the patients who have perhaps not yet developed to have more sustained rectal prolapse, but these are the earlier presentations of someone who will go on to have the full-blown rectal prolapse. And with that hypothesis, we wanted to see if we can show our hypothesis is correct by looking and comparing the anatomy and anorectal pressures and clinical presentations of the patients who have defecation-only rectal prolapse to show that this is an early presentation of the full-blown rectal prolapse that is more sustained and it's presenting at all times.
Got it. I understand. And how did you go about addressing your aims?
So this would have been best really conducted in a longitudinal study, but because we don't really have such information, we decided to compare the patients that are having rectal prolapse at defecation and compare them with the patients who have rectal prolapse at all times, compare their presentations, their symptoms, their medical history, clinical characteristics, and compare their MR defecography findings in terms of the anatomy, how their measures of the pelvis laxity might be different, and also look at the anorectal manometry pressure profile and evacuation characteristics and to compare the two groups to see what are the differences between these groups.
Hmm, hmm. And what were the headline results of your study?
Very good. So we noticed that patients who have defecation-only rectal prolapse, in general, they are much younger than the patients who have more sustained rectal prolapse. The medical history, including presence of the OB trauma, was not really different between the two groups. There are significant differences in terms of the pelvic floor laxity. Patients who have more sustained rectal prolapse, they have more of the pelvis that has a larger volume. The anorectal angle at rest seems to be wider, and it seems that they overall have a more pelvic floor distension at rest. And as compared to the patients with the defecation-only rectal prolapse, those patients with sustained rectal prolapse have lower resting anal pressures on anorectal manometry, and they are more likely to have less sustained of a squeeze. The defecation features during simulated defecation on anorectal manometry was also different with the patients with defecation-only rectal prolapse have more intra-abdominal or rectal pressures at simulated defecation. So they are more likely to be increasing intrarectal pressures when they are evacuating to show the rectal prolapse. But in terms of the evacuation of the rectal balloon, there were no significant differences between the groups, and somewhere around 20% of all these patients, despite having really pelvic floor laxity, despite having the low resting anal pressures, were unable to pass the rectal balloon. And so these differences are really more relying on clinical characteristics, with age being a major component, rectal pressures and resting pressures, as well as the anatomy.
And did any of those results surprise you at all?
Well, this was quite well aligned with our hypothesis in terms of more preserved pelvic anatomy in patients who have the defecation-only rectal prolapse. The fact that they had a smaller levator ani bowl, the volume of the bowl was smaller. They had less of the laxity. They had a more preserved anorectal angle at rest. So these are showing the better phenotype, the early phenotype, perhaps, as we had hypothesized. The fact that the resting pressures were more preserved in these patients with defecation-only prolapse was also showing that these are more preserved of the anorectal pressures. And the fact that rectal pressures were higher in this group, again, showing that they are more likely to have more of the evacuation really straining that is more preserved as compared to the patients with really complete laxity of their pelvic floor, and therefore more sustained rectal prolapse. And I have to say that in terms of the clinical characteristics, we looked at the symptoms in a great deal. We ask our patients about what is bothering them through very detailed questionnaires to identify what are the bothersome symptoms for these patients. Somewhat to our surprise, both groups had a similar degree of real bother with fecal incontinence. And overall, fecal incontinence seems to be a really bothersome symptom for patients with rectal prolapse. Regardless of the subgroup, they both, around 50% of the patients report the fecal incontinence as a really bothersome. And this is quite known as fecal incontinence is associated with the decline in quality of life. And in terms of other symptoms, because we know that rectal prolapse is very heterogeneous, again, in terms of the clinical presentations, we ask about presence of the mucus discharge. This is a spontaneous mucus discharge, and also about pain and discomfort. And we noted that patients who have more sustained rectal prolapse are more likely to have both mucus discharge and pain. And in terms of the symptoms related to difficult evacuation, obstructive defecation syndrome symptoms, they were more prominent and significantly higher in patients who had defecation-only prolapse. And these are the patients who are straining and really trying to increase intra-abdominal pressures to the point that it leads to a rectal prolapse during defecation. Then we looked at our surveys. We used two surveys, Renzi obstructive defecation syndrome score, which is asking about the symptoms related to the constipation having this training. And we also use the Wexner fecal incontinence severity score for the fecal incontinence. And we noted that patients who have more sustained rectal prolapse have higher, significantly higher fecal incontinence in terms of the Wexner score. And in terms of the obstructive defecation, they have significantly lower obstructive defecation as compared to the patients who have defecation-only rectal prolapse. So there seems to be very significant clinical features into these phenotypes as well.
Mm, mm. Thank you. So clearly your paper is an important contribution to the literature, but based on the results of this work, what study do you intend to perform next?
Very good. So we know that, so now we hypothesize that there are differences, the early phenotype as compared to the late phenotype. We understood that there are differences. The patients who are late phenotype have more of the pelvic floor laxity and the anorectal pressure seems to be more affected. The question now is how are some of these patients progress to become the late phenotype? What are the risk factors for progression from the defecation-only rectal prolapse to the more sustained rectal prolapse? Where in this transition can we stop these patients from getting to have more of the deconditioning? And if the early intervention, as we did for all these patients, we offer them the rectal prolapse surgery. But if there are other interventions, such as biofeedback therapy, that we know
Mm.
is going to be addressing the dysynergic defecation, will that be a better intervention for these patients with the early phenotype to prevent them from progressing to have a full more sustained rectal prolapse or not? This is really not known. So doing longitudinal studies for us to really be able to monitor the patients who opt not to have the surgery, but go for more biofeedback and medical options, and really understand what's the natural history of these patients, whether we are able to stop the progression of the pelvic floor deconditioning and prevent them to move on to the more advanced phenotype is the biggest question that we are trying to look at, and perhaps will require a multi-center study, but we are looking into registries and really keeping a registry of longitudinal surveys of these patients and look for the progression.
Thank you. Thanks a lot, Dr. Neshatian. I look forward to seeing that work in print, hopefully soon.
Thank you.
So I just want to say it's a real pleasure
Thank
to
you.
have you join us today on the NGM podcast. And yeah, I want to thank you for taking time out of your busy schedule for this podcast. So thank you very much, Dr. Neshatian.
Thank you so much. It was a pleasure, and thank you. Good luck. Thank you.